जी ओके सो हम थायराइडेक्टमी तक पहुंच गए थे हम. In the last discussion we reached that now thyroidectomy is to be done. So what we are going to discuss is not thyroidectomy, but more so okay, what complications you are going to deal with it. Both things are going to come. Okay, let's revise. So how many types of thyroidectomies are there?
Sir, one is total thyroidectomy. The other one is near total thyroidectomy. The third one is Dunhill procedure. And after that, there is lobectomy.
अच्छा ये बताइए कि आपने अपना कोई माइक तो ऑन नहीं किया हुआ जिससे आपको आवाज
सिर्फ हेडफोन लगाया
और तो कोई आवाज नहीं ना आ रही बीच में.
नहीं सर, मुझे तो आपकी आवाज
आप जब बात करते हैं तो बीच में थोड़ी सी साउंड आती है. अपनी पोजीशन थोड़ी सी चेंज करिए जहाँ बैठे हैं. आप बात करें.
Is it better now, sir?
हाँ ठीक है चलिए लेट्स गो. ये बात इन्होंने सही की कि इट्स अ सब टोटल थायराइडेक्टमी, नियर टोटल थायराइडेक्टमी, टोटल थायराइडेक्टमी एंड डनल operation. There is also one more operation which is lobectomy and isthmusectomy. ये भी बीच में आप शामिल कर लीजिए. When we're talking about these, there are certain definitions which are to be kept in mind. For example, in subtotal thyroidectomy, in simple multinuclear goiter, we leave 8 grams of tissue behind. Whereas in toxic multinuclear goiter, we are going to leave behind 4 to 5 grams of thyroid tissue in each lobe. And near total thyroidectomy, it is 1 to 2 grams of thyroid tissue left in each lobe of multinodular goiter. Total thyroidectomy obviously is the whole thyroid gland. Lobectomy is one lobe is excised with isthmus, and as you know, Dunhill operation will be total lobectomy on one side and subtotal lobectomy on the other side. So that constitutes a Dunhill operation. My question, Ismail, you is, बातें यहाँ पे वेट की हो रही हैं, तो how will you know what is the weight of the tissue which you are left behind? जी इस्माइल.
सर जो इंडेक्स फिंगर है सर
जी
डिस्टल पल्प है
जी जरा ऊंचा बोले.
सर जो इंडेक्स फिंगर है
जी
इसका जो पल्प है सर
ठीक है. आपने कहा जी जो इंडेक्स फिंगर है उसका जो पल्प है अगर उसके इक्विवेलेंट हो तो यू से इट इज 8 grams. So how you have reached to this conclusion? Okay, you see,
sir, thumb placed along the trachea will make 8 grams, and
okay.
1 centimeter cube of thyroid is 1 gram.
And why 1 centimeter cube of thyroid is 1 gram? बात आपने ठीक की.
Sir, इसका reason नहीं.
The reason is, you see, 1 centimeter cube, if you take 1 centimeter cube of water, it is 1 gram. It all depends upon the density of the tissue, how weight it would be. So therefore, roughly speaking, 1 centimeter gram of thyroid, its density is such that it weighs 1 gram. तो बात आपने जवाब आपने सही दी है. That is how it is done. So what you do is you place your thumb on the side and then you find out how much thyroid is left behind. Then we were talking about, मैं रिवाइज कर रहा हूँ पिछले ताकि हम आगे चल सकें, कि how do you argue the choice of thyroidectomy? Now, the choice of thyroidectomy which you want to do, whether it is subtotal, near total, or total, you have to keep 5 points or 4 points in your mind. One is, what are the chances of recurrence of goiter? Then, what are the chances of hypothyroidism? And if it's a thyrotoxic, then what are the chances of recurrent thyrotoxicosis in a toxic goiter? And there are two important structures which could be damaged. So therefore, what are the chances of hypoparathyroidism? And what are the chances of recurrent laryngeal nerve damage? And as you know, in subtotal thyroid, let's talk about total thyroidectomy. Obviously, there is not going to be any recurrence of goiter. Hypothyroidism is always going to occur. And obviously, there can't be recurrent thyrotoxicosis because there is no goiter left. Hypothyroidism, a recurrent laryngeal nerve damage, our chances are more because the dissection is near these glands and these nerves. So it is must to identify these structures in total thyroidectomy and near total thyroidectomy. Obviously in subtotal also, but some excuse can be levered because one is away from the thyroid, so it's difficult if you're not finding how you are locating it, then it's okay. One can do about it. Whereas in subtotal thyroidectomy, the recurrence of goiter chances are more as compared to total. In hypothyroidism, chances are less as compared to total. Recurrent thyrotoxicosis chances are there, but the incidence is much decreased if you leave behind 4 to 5 grams of thyroid instead of usual 8 grams in each lobe, in a case as in a case of simple multinodular goiter. And the chances of hypoparathyroidism and recurrent laryngeal nerve were very less. When we come to near total thyroidectomy, then it is like total thyroidectomy in terms of recurrence of goiter, in terms of hypothyroidism. Obviously, the chances are more than that. But the advantage of this thing is that the parathyroid glands and recurrent laryngeal nerve, they're much safer. Then we were talking about investigations before thyroidectomy. And so कौन सी हम investigations करेंगे? Can you name them?
सर सबसे पहले तो हम फंक्शनल स्केल करेंगे
जी कौन सी करेंगे दोबारा बोलिए आपकी आवाज नहीं आ रही कोई और जवाब दे दे बेशक
अभी आ रही है सर
अब ठीक है
from the initial okay
सर फंक्शनल स्कैन करेंगे T3 T4 एंड TSH सर अगर इनमें से कोई एक चूज करना हो तो दैट इज TSH
ठीक है
तो उसके बाद सर टू नो द एक्सटेंट ऑफ द नोड्यूल्स नोडुलरिटी उसके लिए सर पहले अल्ट्रासाउंड करेंगे सर
See. So in all cases, what you're talking about is obviously we have to do the thyroid profile, which increase of serum 3T, T4, TSH. And then obviously general preoperative investigations are going to be there, which are blood CP, urinary X-ray test, liver function test, renal function test, obviously urology and non-virology. In addition to hepatitis, COVID serology is going to be there. It's become a norm now. And then there's specific investigation. Let me recall what we were talking last time is thyroid scan. The indication nowadays possibly is always there is a toxic patient, especially with toxic multinodular goiter. Ultrasound is there. It will give you an idea about the size of the thyroid and other thing. Extrathoracic inlet. Now, extrathoracic inlet you're going to do in few patients because the importance of extrathoracic inlets is not only the retrosternal extension of goiter, it gives you a fairly good idea that is the trachea shifted or not, because it is important to know the shift of trachea, especially from anesthesia point of view when they're putting in a tube. So therefore, clinically, if two things are present, it is must to have a extrathoracic inlet. Number one, clinically, there is retrosternal extension of goiter, or the trachea is shifted away from midline, or trachea is not palpable. So we have to do that. FNAC, you are already told, it's a solitary thyroid nodule. Aap karenge. Then a suspected case of tumor, and then in a multinodular goiter, if there is a dominance of a nodule. Then two are very important. One is indirect laryngoscopy and serum calcium. Important thing to remember is that they are to be done all cases. But what are the cases in which you must do these two? I think,
sir,
जी,
सर एक तो सीएमए जरूर कराएंगे सर.
किसमें?
कैंसर में सर.
आपकी आवाज कटती है बीच में. आपके माइक
सर मैलिग्नेंट पैथोलॉजी में जरूर कराएंगे सर.
ठीक है.
पैथोलॉजी. और दूसरा सर ह्यूज थायराइड गोइटर में बहुत ज्यादा ह्यूज, उसमें जरूर कराएंगे सर.
बिल्कुल ठीक है.
और मेडिको लीगल पर्पस के लिए सर.
ठीक है.
That is the third.
So therefore, what you are identifying is that there are certain cases in which they are must to be done. इसमें if you are planning to do, जो मैं ऐड करना चाहूँगा, if you are planning to do total thyroidectomy, then they must be done. If you're doing near total thyroidectomy, then also it must be done. Then if there is you are operating for a recurrent goiter, then it must be done. Then large goiter, आपने बताया, there are technical difficulties expected, obviously. Fear of legal litigation, आपने बिल्कुल सही बताया कि उसमें भी आप करेंगे. And obviously cancer cases में आप करेंगे because you plan to do is a total thyroidectomy. And especially if tumor is such that अगर local invasion आप involve करते हैं, ऐसे कोई chance extra thyroid है तो आप करेंगे ये. So you can understand this thing. Okay, all those cases in which there is increased risk of damage to parathyroid or recurrent laryngeal nerve, then they must to be done. अब हमने जब बात की है तो देखें तीन मेन स्ट्रक्चर्स हो गए ना. If you think of complication के हवाले से बात करूं मैं. A complication could be of a blood vessel, meaning by bleeding is a complication. Now, bleeding can occur because of a ligature which has been split, which has been slipped, which is again a rare, not that common, or some bleeding point has remained unidentified, or blood pressure was kept low because of certain reason, and then it was not raised to normal during before closing the wound. Second is obviously your recurrent laryngeal nerve, and third is parathyroid glands. And very rarely trachea. One can injure that. I am going to ask question in different way because you're not going to get patients like that. You are either going to get patients with a breathing problem, or you're going to get a patient who is going to give you odd complaints like tingling sensation and numbness in the hand, or sister calling you that patient is he's having fits or something. In fact, they're not fits because they are the hypocalcemic effects in which the abnormal positions of hands are there. Then there could be even bleeding without respiratory problem, and in toxic patient, thyrotoxic crisis. These are the complications. So let's start with the breathing problem. Now, Ismail, you tell me that you are a registrar, and sister rings you up. Okay, she's seeing this thing. It's difficult for a patient to breathe. So what are you going to do?
Sir, post-op patient.
Post-op. We are talking about post-op complications. Or post-op complications after thyroidectomy.
Sir, the initial thought that will come in my mind is that is due to tension hematoma, and I will do first of all I will release the suture line so that the tension under trachea and the blood vessels is released. Then I will secure the airway.
Then you will secure the airway.
Sir, and shift the patient to OT and see what is the source of bleeding, from where the bleeding is coming, and try to secure that.
Okay. But that's the correct approach. So the step one, first thing would be, when you're going to examine you're going to come and examine the patient.
Sir.
Or if there's a time to reach to the place, like if you're at home or away, then you're going to tell the sister to remove the stitches. So can you remove the stitches of the skin and remove the midline stitches? That is.
After removing the stitches, then we assess again that the respiratory problem is resolved or not. Then we will move to another step.
Very nice. Very nice. This is a very important point. Problem is respiration. Problem is not bleeding. That is a different thing. That the bleeding which has occurred, that is resulting in edema of the larynx, and that is resulting in, that is agreeable. But at this time, we can lose the patient because of breathing. So first step would be, as soon as you are going to come, you're going to evaluate the patient, which is not going to take much time because of the dyspnea that will be pretty obvious. And then you see the neck, you might see some swelling of the neck. May not be huge swelling, but you might see some swelling of the neck. You open all stitches of the skin, all stitches of the platysma, and midline stitching of investing layer of deep fascia, जो आप midline में आप लगाते हैं कई दफा. इन तमाम को आप जो है खोल देंगे. You're going to open them up. Then, once you have opened it up, then if there is a clot present in front of you, and if clot is protruding out, to remove the clot. Nothing is going to happen. And place a gauze piece. Now what he is saying is very important. You assess the respiratory difficulty has subsided or not. Because the way you're going to proceed is going to become different. Now once the respiratory problem has finished or it has become less. Now you have the time and the problem is deal with the bleeding. But if respiratory problem has not subsided, then you have to do something there and then so that patient respiration is maintained and oxygen saturation does not fall. It depends upon the skill and facilities. At the minimum level, putting in a needle and cricothyroid membrane. Or if the facilities are available, you can even do tracheostomy if it is very severe. But if the OT is near and everything is near, you can just put in a needle and take the patient to OT. But if you have the expertise of putting in an endotracheal tube, if you have the expertise, then you can put an endotracheal tube, because you cannot put an endotracheal tube in a patient who is conscious. He won't allow you. But if you have the expertise, you know which medications to give and to put an endotracheal tube, then you can even do that. But the simplest and easiest ways, I think the best answer would be do needle thoracosynthesis and take it to operation or to a table if you do not know other things. Now, once you take the patient to the operation theater, फिर क्या करेंगे? Then what you're going to do? Anyone?
Secure the bleeding.
Hello, sir.
Okay. So before bleeding, won't you like to do something? Obviously, you have
pass the ETT and then secure the bleeding in general anesthesia.
Yes. Now what is happening is, when you are answering me, again, the brain thinks in such a way that very obvious thing one doesn't like to mention because it's understood. Obviously, it will be under general anesthesia. अगर mention कर दें तो it's always better. And from where the bleeding would be occurring? What do you think?
Sir, mainly the bleeding occurs from small areas such as near the Berry's ligament, the small vessels, and most of the time the bleeding has subsided. That is because of the hematoma or the edema effect that is causing the respiratory problem, sir.
I think that's a very good answer, because you see, the common thought which comes in the mind is that some ligature might have slipped. This is the common thought which comes. But it's not so. The commonest site of bleeding is the remnant thyroid tissue, which is left behind. From its surface, it is oozing. So if you have done the total thyroidectomy, as he is saying, then the surface on which this thyroid is lying, from there, very small vessels from which the bleeding occurs. And many times the bleeding has stopped by the time you open, because of the pressure of the hematoma, which remains on the vessels, and the vessels bleeding stop. But main thing to remember is that it is the remnant of the thyroid. An important step possibly would be is, before doing that, once you remove the clot, then everything is stained with clot, isn't it? And even if you remove the clot, small pieces of clot, fragments of clot are deterrent. It is always a good idea, if it is not obvious, your bleeding is that obvious, or if you are confused which actually the exact point, then clean the bed with normal saline. Once you clean the bed with normal saline, the small clots or fragments of clot which are left behind, which are stuck to or to the surface, they are washed away. The staining of the tissue is less, and you can see much better. And even the saline, you see the thyroid when removed is at the depth, so saline is going to remain there. So any bleeding point, the blood which is coming out a very very minutely, it's very easy to identify in water as the blood comes towards the surface. So you're going to do this thing. My question is that how does, if a ligature has slipped, how that is going to present? Yes, anyone?
Sir, on inspection, there may be visible spurter because of the high pressure artery.
Okay. So that is right. There could be another scenarios also, and which are in fact more common than that. Okay, what is happening is we are going to start from here again. So time is running out. So what I'm going to do is I am going to stop it now and rejoin again. Okay? Is it okay?
Yes, sir.
Yes, sir.
Thank you.
All right, sir.